Welcome to Module 1, an overview of the Early and Periodic Screening, Diagnostic, and Treatment, or EPSDT benefit. This module is part of the CMS web-based training for Form CMS-416 dental data reporting. Please visit the CMS web-based training homepage at medicaid.gov to find links to modules covering additional topics. There you will also find a document that contains links to all the resources mentioned in this module. For questions about the Form CMS-416 or the Oral Health Initiative, you can access the complete Form CMS-416 reporting instructions on the EPSDT page on medicaid.gov or email the EPSDT Technical Assistance mailbox at epsdt@cms.hhs.gov. This module will cover several learning objectives and additional content related to Medicaid's Early and Periodic Screening, Diagnostic, and Treatment, or EPSDT benefit. After completing this module, you will understand the history, goals, and basic requirements of the EPSDT benefit, and you will be familiar with the Form CMS-416 and the Oral Health Initiative. The content covered in this module includes the history and goals of EPSDT, the components of the EPSDT benefit, state requirements for administering EPSDT benefits, an overview of Form CMS-416 reporting requirements, and an introduction to the Oral Health Initiative. Let's look at the history and goals of the EPSDT benefit. EPSDT is a Medicaid benefit for children and adolescents. Over time, the EPSDT benefit has expanded to cover a large population. Let's review some important dates in the history of EPSDT. In 1965, Medicaid was enacted mandating coverage for children receiving Aid to Families with Dependent Children, or AFDC, and making coverage optional for other very poor children. In 1967, the EPSDT benefit was added to promote healthy child development and treat conditions that sicken children. In 1972, the Supplemental Security Income, or SSI program, was enacted, providing cash assistance and Medicaid to children with disabilities. Between 1984 and 1990, through incremental steps, Congress expanded Medicaid to cover all poverty-level pregnant women and children born after September 30, 1983. States were given options to extend coverage to low-income children and women, such as extending coverage to individuals with incomes slightly above poverty. During the same period, the Omnibus Budget Reconciliation Act of 1989 expanded EPSDT to ensure that all treatments allowed under the definition of medical assistance are covered in all states in response to evidence of limited coverage for children with mental and developmental disabilities. Finally, the Balanced Budget Act of 1997 established the State Children's Health Insurance Program, or CHIP, and made the EPSDT benefit optional for children covered under separately administered CHIP programs. Additional information about the EPSDT benefit is also available on medicaid.gov. Let's talk more about the different components of EPSDT. This table illustrates how the 5 components of the EPSDT benefit contribute to child and adolescent health. These components include early, periodic, screening, diagnostic, and treatment. First, let's look at early. It is important to assess and identify problems early in order to diagnose and treat conditions before they become more complex. It is also necessary to conduct periodic health checks. This includes checking children's health at age-appropriate intervals. Each state determines its own periodicity schedule after consultation with recognized medical and dental organizations involved in child health care. Many choose to align with the American Academy of Pediatrics' Bright Futures guidelines. It is also important to conduct screenings. Children should receive preventive care and screenings that address the needs of the whole child, including vision, hearing, dental, behavioral, and developmental screening. Diagnostic testing is the next critical step. If the screening shows signs that there might be a health problem, follow-up diagnostic testing and evaluations must be provided. Finally, necessary treatment should be considered. States make medically necessary treatments available to children insured by Medicaid and some CHIP programs. What are some of the state responsibilities for EPSDT administration? States have several responsibilities related to administering the EPSDT benefit, some of which are communicating with beneficiaries to ensure awareness of and access to EPSDT benefit services, setting standards and reimbursement methodologies for services, communicating with providers and managed care organizations around EPSDT benefit service policies, and collecting and reporting EPSDT data. This list is not comprehensive regarding state responsibilities for administering EPSDT benefits. You can find additional details in Chapter 5 of the State Medicaid Manual, available on cms.gov. More information is also available in the EPSDT Coverage Guide, available on medicaid.gov. Now let's talk about EPSDT reporting. As part of administering the EPSDT benefit, states are required to collect and report data on levels of service utilization to CMS. States submit data to CMS annually using the Form CMS-416. There are a number of resources available for Form CMS-416 reporting. You can find resources related to the Form CMS-416 on the EPSDT page of Medicaid.gov, including the web-based training homepage where you can access additional training modules. These resources include Form CMS-416 instructions, a frequently asked questions document, a CPT-CDT crosswalk, the Form CMS-416, links to the EPSDT Technical Assistance or TA mailbox to submit EPSDT-related questions, a worksheet of common definitions, and a link to the Form CMS-416 web-based training homepage. There is also information available about the Bright Futures Guideline at brightfutures.org. How do states use data from Form CMS-416? CMS and states can use the data reported on the Form CMS-416 in various ways, including to assess the effectiveness of state Medicaid programs or CHIP Medicaid expansion programs in administering the EPSDT benefit, to monitor state performance on quality improvement objectives, and to identify areas for improvement. Let's talk a little more about how states and CMS are using data from Form CMS-416. One area for improvement that is monitored using Form CMS-416 data is children's use of oral health care services. In 2010, CMS launched the Oral Health Initiative, or OHI, with specific national and state goals. The goal of the initiative began in federal fiscal year 2011. This goal is to increase by 10 percentage points the percentage of children ages 1 to 20 that are enrolled in Medicaid for at least 90 continuous days that received a preventive dental service. Preventive services included under the goal are cleaning, sealants, and fluoride treatments. They do not include exams or x-rays, which are considered diagnostic services. The data collected on the Form CMS-416, specifically in the dental lines 12A through 12G, enables states and CMS to track progress related to oral health. In particular, line 12B helps CMS track the progress towards meeting the OHI goal. For more information on the Oral Health Initiative, please visit the Dental Care page on Medicaid.gov. Why is the Oral Health Initiative important? Here's some context. Tooth decay remains one of the most common chronic childhood diseases, causing pain, loss of school days, infections, and even death. Despite recent improvement, fewer than half of children enrolled in Medicaid are receiving at least one preventive dental service in a year, and there remains a wide variation across states. CMS is committed to increasing access to dental services for children enrolled in Medicaid and CHIP. Additional information on common chronic childhood diseases is available through the Children's Dental Health Project at cdhp.org. For more information on Medicaid enrollment, please visit medicaid.gov. Let's review the Module 1 summary. In this module, you learn that EPSDT is a Medicaid benefit for children and adolescents. It also covers children insured by CHIP Medicaid expansion programs in some states. EPSDT has expanded over time since its inception in 1967. It is intended to increase children's access to health care, including prevention and treatment services. You also learn that states are required to report data annually on their EPSDT utilization using the Form CMS-416. And finally, you learn that data from the Form CMS-416 is used to track progress on quality improvement goals such as the Oral Health Initiative. Congratulations! You have completed Module 1, Overview of the Early and Periodic Screening, Diagnostic, and Treatment, or EPSDT benefit. To access Module 2, other training modules, and relevant Form CMS 416 resources, please visit Medicaid.gov. For questions about the Form CMS 416 or the Oral Health Initiative, access the complete Form CMS 416 reporting instructions on the EPSDT page on Medicaid.gov or email the EPSDT Technical Assistance mailbox at epsdt@cms.hhs.gov.